Okay, so the
Yes.
next 15 minutes or we will be just seeing uh, whether surgical interventions can be done on ECMO or not, and how we can do it. So it's obviously the dilemma comes to our mind because we are anticoagulating the patients. So how can we do a surgery? In any kind of surgery, even for non-ECMO patients, the surgeon is always saying this patient will bleed more. I won't be able to do the surgery. So when it comes to the ECMO patient, they will be more in this kind of dilemma that should we go ahead? Because if you are giving heparin, then the patient is going to bleed. And if you stop the heparin, and then you may land up in clot in the ECMO circuit. So this is the fine balance that we have to maintain. And secondly, any kind of surgery leads to a hypercoagulable state in the patient. So we have to remember this is the basic fact for any kind of surgical intervention. You have to balance the anticoagulation in these patients. So when do we do surgical procedures during an ECMO run? So it can be to treat any underlying problem that has dropped up or that is there, or as a general management of the part of the patient. So suppose the patient is having a vascular injury, well, cannulation, you are correcting it, or there is a distal perfusion flow is not adequate, you are surgically doing it. All those things are a part of the managing the patient on ECMO. Or sometimes we have some problems which is coming up during the ECMO run, or the patient has this problem for which the patient went into ECMO and we have to treat that. So I'll go, before I go into the major surgeries, a few points that I want to iterate here, that simple procedures on ECMO where we are doing invasive procedures like insertion and removal of lines, they have to be very meticulous. While inserting a line, we have to do it usually under the ultrasound guidance, and always avoid multiple punctures because they are prone to bleed. And if there are multiple punctures, you will find that there are even small skin punctures, they will be continuing to bleed. And suppose we have had a false arterial puncture, that is arterial puncture while placing a central line, that is a nightmare because then there is a chance of hematoma during this after the procedure. Even while removal, you have to be very particular because before removal, we always check the coagulation status of the patient, and always we put a long local compression for the bleeding to stop. And even after the bleeding has stopped, we come back repeatedly and see whether there is any bleeding or hematoma at the site or not. And very particular, this we have found in our clinical experience that in the first 24 hours, these patients usually develop a acquired von Willebrand syndrome. So they are coagulopathic in the initial run of ECMO, and at that point of time, we usually avoid removal of lines. So after a couple of days, once this is settled down, the patient is not bleeding, that is not coagulopathic, then you can remove the lines. Usually, we do not stop heparin unless APTT is grossly deranged during the insertion or removal of lines, or if patient has developed a hematoma while insertion or removal of line. At that point of time, we may need to stop the heparin for a few hours. Secondly, one very common procedure that we do in these patients, a simple Riles tube insertion. You will think why we are talking about Riles tube insertion. That's because these patients, their nasopharyngeal mucosa will be very, very edematous and friable, especially after a few days of ECMO. And Riles tube we try to put the RICE tube always before we go for the ECMO cannulation. So before we put the patient on heparin, we try to put the patient on this RICE tube is inserted. And if we have done the ECMO cannulation, we usually try to avoid the nasal route and try to put a orogastric tube. That will be a better choice, because nasal mucosa, if there is a small nick, that will cause a huge bleeding. And we have had to transfuse multiple units just because of the bleed from the nose. If there is a bleed, you have to go for nasal packing, both anterior and posterior, to control it. And you will have to pray to God that it gets controlled early. Coming to the procedures that we do, like surgical procedures, the commonest surgical procedure that we do is a tracheostomy. So the tracheostomy on the ECMO is both easy and difficult. Why easy? Because you can stop the ventilation if the patient is on VV ECMO for a few seconds. That is not a problem while you are putting the tube in. But the difficult part is the patient will be on ECMO and on anticoagulation. So even after tracheostomy, for the first 48 hours, there is significant bleeding in many of the patients. And we face this challenge more during the COVID times, because those patients were very, very prone to bleeding than our non-COVID patients. And if we have had to take out the tracheostomy tube by keeping a guide wire in, and then cauterize all the structures deep down up to the level of the trachea, so that there is no further bleeding. So that has been a problem in some patients, but mostly if you are careful, percutaneous tracheostomy is easy and is very frequently done. And we try to put the tracheostomy in as early as possible. Why early? Why I'm saying, because see, these circuits are usually heparin coated, and in the early phase, you can stop the heparin for a significant amount of time if the flows are adequate and your chances of circuit clotting is not there. And as the patient is more and more on ECMO, after a few days, there is more chance of clots forming in the circuit if the patient is not on anticoagulation. So that thing that we have to remember. And early tracheostomy, you can start weaning the ventilation, or you can start mobilizing the patient. The very early on, you can stop after 48 hours, you can stop the muscle relaxants, and you can start mobilizing the patient, start feeding the patients orally. And this will help to improve the outcome of these patients. But the only problem in early tracheostomy is that when you have to prone the patient multiple times, then you have to be very careful with the tracheostomy tube. It is easier to prone with an oral tube than the tracheostomy tube. So ECMO can be used to stabilize the patients prior to surgery. This is a very common scenario in cardiac surgery, where if a patient you have received is crashing in severe cardiogenic shock, and the patient is not in a position to go for the surgery. So when this thing occurs, we are in a soup, what to do. So if we can initiate ECMO early in these patients, then we can minimize the other end organ damages. And whatever end organ damage has occurred, that can reverse within a couple of days. And after that, some of these patients may be amenable for further surgical procedures. Cardiac procedures can be done. So this is a situation where your ECMO is a bridge to the surgery. So if we take these patients without the ECMO support, without the initial stabilization on ECMO, they invariably their outcomes are very, very bad. And since these patients are on ECMO with a heparin-coated circuits, use of anticoagulation is not significantly high in the initial period. And finally, if the patient needs to be on pump, on cardiopulmonary bypass during surgery, then these ECMO cannulas for VA ECMO can itself be used for our cardiac surgical procedures to go on CPB. So that way we are safe. But always remember that these patients, since we are going, if we are going for cardiopulmonary bypass, we have a huge dose of heparin going in during the surgery. And if possible, we usually try to give protamine at the end of the surgery if the patient is tolerating some period of off pump. And then we see whether the patient needs ECMO support or not. If the patient needs ECMO support, then we connect to the ECMO circuit, which has been primed with at least 50 milligram of heparin. So in that way, we can reduce the effect of heparin on the bleeding, post-operative bleeding. Otherwise, if the patient has been highly anticoagulated with full dose of heparin and we are continuing on ECMO, there is no way out than keeping the chest open in these patients, because they will continue to bleed in the next few hours. And we do not start heparin again in these patients unless the bleeding has been controlled a little bit. And when the patients are put on ECMO for these problems, we always assess the presence of whether the patient is improving or not. We do not take the patient on to the theater unless the patient is showing signs of improvement. The cardiac function is slightly improved, the inotropic requirement is coming down, the lactates are coming down, the patient is passing urine, or the liver functions have improved. All these end organ problems are recovering. Only then we give the insult of surgery. This surgery is an insult to the patients. Whether this patient will be able to take the insult will depend whether the patient is recovering or not. And usually the surgery is done at least 40 to 72 hours after the patient has been on ECMO, stabilized on ECMO. And it has been found that if you take the Euroscore of these patients who went for surgery after stabilization of ECMO, the Euroscore was almost 67. That is, 67% of these patients will die if they are going for surgery. But once the patient has been stabilized on ECMO and then taken, bridged with ECMO and taken, the mortality rate comes down to only 16% in these patients. So there is a significant improvement in mortality in these patients. So always remember that ECMO as a bridge to cardiac surgery has been used very frequently in many kinds of situations, and their outcomes have been much, much better. Other kinds of surgeries, lot of other surgeries can be done. You can see thoracotomy, laparotomy, fasciotomy if there is any lower limb problems, chest drain, thrombectomy, all these can be done on ECMO. If the patient has had a trauma surgery can also be done. All these things can be done on ECMO. There is no problem. We have to assure, as an ECMO physician, we have to assure the surgeon that you will provide him a good field so that he can do his work and the chances of bleeding will try to be controlled. So all these patients are on lot of gadgets, and shifting in and out of the theater will be a hassle. That you have to always remember. That is transporting in and out of the OT. ECMO can also be used as a bridge to organ donation. So suppose a patient, you have put on VA-ECMO and the patient has a cerebral bleed. This was a patient, young patient who was put on VA-ECMO, but on the third day developed a huge cerebral bleed and then had a brain death. So we went for an organ donation in these patients. The abdominal organs could be taken and uh, given to other people who are in need. So ECMO can be used as a bridge to organ donation. Even if the patient is a brain dead patient whom we are seeing that we are waiting for the other teams to come in between, if the brain dead patient becomes hemodynamically unstable, can be put on ECMO and continued with the proper circulation going in. So the organs are preserved and they can then be taken for organ donation. Always remember, these patients, they because the surgeons who are taking the organ, they are very concerned about their own organs. There is 3-4 teams will be there. They will be concerned about their own organs. They are least bothered about the hemostasis part. So a lot of bleeding you may encounter in these patients. They just think that this is the patient, since this patient is not going to survive, what's the use of doing so much? We quickly take the organ out, go to our own place, and put the patient, put it in the our own recipients. So we have to be very careful, because once the bleeding starts, your flows will start to fluctuate. And also, if anyone is clamping the IVC and your cannula is there, you have to be very careful about that. And if there is any nick in the IVC, it will immediately entrain air and your ECMO flow will stop because of the air in the circuit. All these things we have to remember during ECMO for organ donation. Coming to this last slide, managing anticoagulation during surgery on ECMO. This is a $1 million question, how we need to manage the anticoagulation. Because there is, if you ask me, there is no definite answer to it. It is all individualized to the patient's need. First and foremost, if the patient is on ECMO on very recently, you can very easily stop the heparin, continue the patient without the heparin for a few hours and take for surgery. The heparin effect will be gone. You will get a good feed. But after a prolonged ECMO run, if the patient is needing a surgery, there stopping anticoagulation will be difficult, but still we have to stop the anticoagulation. And you have to ensure that the patient's ECMO flow is more than 4 liters, around 3.5 to 4 liters. Then the chances of clotting within the circuit will be a little bit less. Another point to be kept in mind, because after a few days, after 2 weeks or 3 weeks on ECMO, the patients will be developing sepsis, or the DIC platelet counts going down, fibrinogen going down. All those things you have to see before you take for surgery and correct. When you go for surgery, you keep adequate products in hand for transfusion during the surgery or after surgery. And when to start heparin again? Only after you have finished the surgery and you're sure that there is no significant bleeding, you can go for restarting the heparin.